Great to hear.
All right, over to you.
Okay, hello everyone, Bula. And thank you so much for taking out your time to come and listen to me chat about asthma education clinics that we had set up in Fiji. Just a second.
Oh, more technical issues.
Okay, so just a little bit of an overview. We all know what asthma is, one of the non-communicable diseases, whereby you've got swelling and narrowing of airways upon exposure to allergens. There's airflow restrictions, which can be life-threatening. And the diagnosis of it, there's no single test. They do airflow tests, allergen tests, which are not readily available in the Pacific, from what I remember, as well as a trial of medications that would be responsive for asthma. So showing a little bit of reversibility. The main bit is that asthma is reversible and can be controlled. Sorry, bear with us. Okay, just a little bit of facts from Fiji. So the Ministry of Health put out some data from the year 2010 to 2014, saying that there were 2,285 asthma cases that presented to the hospital, and 6.6% of those admissions resulted in deaths. It's a pretty big number for my small island nation. WHO in 2020 then said that 3.38% of all total deaths in Fiji were that of asthmatics. That's the 5th highest mortality rate in the world. Our challenges that they found were the lack of knowledge on how to use medications, interrupted access to medications, so whether this was through the hospitals provided by the government, and then lack of financial backing on the patient end to be able to then source these medications from the pharmacies, and lack of ongoing treatment. On the ground at this point in time, so I was working at the Colonial War Memorial Hospital. I used to work across ICU, ED and all. So we started seeing frequent asthma presentations to ED, or rather I started noticing that. Late presentations to the emergency department, which subsequently would lead to intubations of these patients, either going to ICU or then heading on to the acute medical wards. The most disheartening bit was to see deaths. And these deaths would be in a lot of the younger generation, and that wasn't great. Well, the seed was planted about reviewing the asthma care pathway by this ED team. And I was reminded by one of the ED doctors just this morning that really it wasn't them, but a collaboration amongst the stakeholders. In the Pacific, it's very common for us to, it's a small place, everyone knows each other. So meeting over dinner, having a little bit of a talanoa session, that's how the idea for the asthma education clinic came about. We were just looking at trying to suss out what actually asthma care in Fiji was like. So then we had a look, and the first thing that was sitting right there in our waiting rooms at the ED department was an asthma station. The pictures show you would comprise of chairs, a nebulizer, and a table. You'd find these very commonly across all hospitals and healthcare centers in Fiji. What used to happen was there was a 3 nebulizer culture. So anybody with an asthma attack would come to the hospital, sit on those chairs, get nebulizers until their symptoms were controlled or looked to be under control, then would head home. The other issues that were highlighted were that patients didn't believe that rescue inhalers or your salbutamol inhalers actually worked. So there was a heavy reliance on nebulizers. There was basically no use of preventers. They were being given out, but you could see from chats with the pharmacists that patients would just say, no, I don't need that one, and move on. And a surprising one was the use of oral salbutamol, which I think has been phased out years ago. Then there was the lack of knowledge. And I think the Ministry of Health website for Fiji said it was a lack of understanding on how to use the medications. We found that there was a lack of understanding across the board on what the condition or disease was about, what the medications did, what the flu rescue medication and the brown preventer, what the purpose of that medication was really, how to control your asthma across the board. We just hadn't given the tools to all these asthma patients out there to be able to manage their asthma. Then there was no follow-up clinics. And so we started thinking about why all of this existed and started questioning where the guidelines were at. So the overall care for asthma, did we have any respiratory guidelines that had stated what the best practice for asthma care was? So we developed a game plan. The ED team decided to review all its patients presenting with asthma at CWM. They would say, hey, you'd get your nebulizer, but you also need to stay back to be reviewed by the doctors. The physios said, fine, we'll come down to ED and have a look at the inhaler techniques to try and see what was amiss, whether that was a problem or not. We thought, okay, let's educate our own health staff on inhaler and spacer use so that regardless of where an asthma patient meets a health professional, we were all equipped to be able to educate them at any point in time, whether it be at ED in CWM or one of the remote health centers. Lastly, we thought, hey, why don't we establish an asthma education clinic? Our challenges, the existing culture, it was so difficult to then, not only in the patient population, but within the health professional population, to try and create a shift from the 3 nebulization cycle. One of the biggest, barriers was the internal medicine department consultant had itself, who believed that, asthma wasn't a problem, that we had bigger problems like diabetes, stroke, high blood pressure, cardiac issues. They definitely are a big problem, but he just didn't see the asthma deaths as being significant enough to warrant a review of the respiratory guidelines. So he did say to us, oh, that's great, you found something, a disease you like, so that you can carry this forward. Resources, we basically, resources, or finding resources in Fiji is pretty difficult. So we looked at what we had. We looked at the medications, we looked at education pamphlets, we looked at staffing and everything. Everything was a challenge at that point in time. Physical space to run a clinic. Physical space to run a clinic. So I'm going to put some pictures up. If you can see on the far right of the screen, you see Dr. Room 10. There were no consultation rooms. So all rooms had to be a doctor room, and I was not a doctor. So I couldn't get a room. That was really tricky, because I went to the nurse in charge of special outpatients and said, could I be allocated a room for 2 hours? And she said, oh, I'm really sorry, you're not a doctor, you can't get a room. So again, I had to go up to the superintendent of the whole hospital and say, could I please be allocated a room for just 2 hours on a Friday to run an asthma education clinic? We had problems sourcing spaces. That's when we found out that through the Fiji Pharmaceutical and Biomedical Services, that there were only 3 spaces being ordered every year for everyone in Fiji. Moving on to patient education. So we found a space, started doing patient education. The first few sessions, or after the first few sessions, all the physios came back together, put their heads in and said, oh, are we doing this right? So patient education is not really about the instructions and the information we're there to give them. Of course, it is in a way, but we realized we needed more skills. We needed to learn how to listen, build rapport, recognize the patient's learning style, their literacy level, the language that they understood. Take into consideration the patient's perspective of their own disease, their asthma, their control, look at some of the barriers, look at some of the superstitions associated with the care that was being provided, asking the right questions at the right time. So if you're listening to your patient, you're actually going to ask questions relevant to their concerns. And that was very important, to understand what's meaningful to your patient so that the goals that you set are in partnership. Because if you've set goals that are meaningful to you rather than your client or your patient, there's no way of winning this. And the bottom one was taking your time. So we sat down and said, hey, you know, the first clinic or the first time somebody comes for an appointment may just be about chatting to them about their difficulties rather than going into the different aspects of education or the different things that you need to cover under patient education. And I'm just going to throw this slide out at everyone. We all know asthma education is to do with identification of, avoidance of triggers. One of the main thing was that most of our patients back in those days did not know what their triggers were. So we had to send them to do some homework. And it was really funny for some of the patients because they're like, what do you mean? What are triggers? So we had to ask them to keep a logbook to say, you know, is it when you garden or is it when you go out to, you know, to the market? What is it? We have to find a pattern to figure out what your triggers are. Talked about preventers, how they work, importance of spacers and inhalers. We used to demonstrate it to the patient and then watch them show us how they would use it at home. Self-monitoring strategies to identify worsening of asthma control, because, you know, your patient's not with you 24/7, or anybody who has asthma, if they don't know how to recognize deterioration in their own symptoms, they would not know when to come to the hospital. So we didn't want people to present so late to the hospital anymore. Asthma action plans. The first time I spoke about an asthma action plan to one of the senior internal medicine doctors, he asked me what they were. And so a part of my bit with education was to really talk to the doctors about what these action plans could be. Because I, as a physio, I can educate them on what the action plan means, but I can't change dosage of medications or say, oh, you know, just take 5 more puffs of your inhaler when you start seeing a deterioration in your symptoms. So that was the other bit. Then we were conducting lung function tests to help us keep a track of how all our patients were doing and be able to identify when they were sort of, you know, going down the track or deteriorating. And a little bit of the physio aspect of things that we should be doing with asthma is exercise tolerance, really how this translates into function, things that are meaningful and goals, functional goals for them. Some success stories. So 2 that really stood out to me. There was a 34-year-old female who had 3 children. And the first thing she said to me when she came to the asthma clinic is, I just want to be able to do my housework and be a good mom. And I, at that point in time, couldn't understand what that meant to her, but that was her goal. And over the course of the 6 months that we went through things, we identified her triggers. It was cooking near our kerosene stove, so the fumes from that. And she used to do it daily. Having a woolly blanket, having dust around the house. So the rugs needed to be changed. Simple things around her that helped us control her triggers, then, you know, managing her asthma, then slowly starting her onto some basic exercises of going to walk for 10 minutes or so. At the end of 6 months, she came to the clinic with her husband, and the 2 of them were in tears because she was back to being herself again and thinking of going out and looking for work. The other person that really stood out is a 32-year-old male who used to come in. He had about 5 ICU admissions in a span of 5 months, being intubated. His aim was not to go onto that breathing tube ever again, because, you know, he'd be on paralytics, couldn't remember days at a time being on the ventilator and then waking up feeling so weak, not being able to go back to work. One of the main things with him during the clinic we found out was he didn't use his corticosteroid inhalers because he had that funny taste afterwards. And a friend of his had said, oh, that's how a friend of mine lost all his teeth. So it took a lot to get to that, but that's when we said, okay, we did extensive education to try and break that thought process. Okay, Now, the bigger picture things that we did in the background, we met with the National Advisor for NCDs to look at the policies. That was Dr. Tukana at that point in time who said, never has there been a project or program run to combat NCDs that has been successful. All projects have fizzled out by the time the grant money finished. So he said, really look at what you're doing. Really think about getting your stakeholders, your patients on board when you do set up this clinic. Look at how to implement it, evaluate it every 3 months or so to see how you can improve this. Try and use local resources really to prevent reliance on grants. So those are the things he helped us do. So we looked at the policy and we actually put the asthma clinic as part of the strategic plan for the Colonial War Memorial Hospital to combat NCDs, which means that that was a physical representation of something that we had in place to fight an NCD. The implementation of guidelines. So these were the respiratory guidelines. I don't think everything that we proposed made it onto the guidelines, and it took 5 years for that to, I guess, become confirmed. But a lot of the things that we needed on there, spacer use of inhalers, use of preventers, I think the asthma pathway of medication administration, depending on the severity of asthma exacerbations that Lucy had talked at the beginning, is part of it. Working with the pharmacy people really to try and increase the number of inhalers that they order so that, you know, we don't consistently run out of medications and, you know, then tell the patients to use these medications that are not available to them. Training, we consistently put a lot of effort in training our nursing staff, the doctors, the physiotherapy staff, the physiotherapy students. We incorporated it in their training when they came in to do an acute physiotherapy rotation, to take the physio students downstairs to the asthma clinic and train them up so that they were ready when they joined the workforce. We also did the same with medical students, because I don't think, I mean, if we didn't have the internal medicine doctors aware of an asthma action plan, I highly doubt it was covered anywhere in, you know, maybe medical school. Then we did a lot of media awareness campaigns, and we were supported by the National Advisor for NCDs, as well as the Fiji National University dean at that point in time. He put a lot of funding in trying to help us set up the clinic to begin with, donated us parameter, but also helped us set up these radio interviews, these newspaper interviews to create more awareness in the wider group out there. And then sustainability. From day one, from the word go, when we thought about the clinic, we wanted it to be sustainable. We wanted to do things in a way that, you know, come time, any of us not being there, the clinic would continue. And this is the team. So you see Dr. Anne Creighton. You see some of the doctors there. If any of you've been to Fiji, there's a pharmacist there. This is us. And at this point in time, none of us are there in Fiji, but the clinic is. And it's continuing to do a lot of good work, I'm hoping. Any questions? Erika.
Whilst you're maybe thinking of questions out there, can I ask you a question, Raksha? So, really interesting talk. Thank you ever so much. Very informative. And I very much understand that it hasn't been an easy journey. It has been full of challenges, but also full of good stuff as well. What would you, if you were speaking to a team that were thinking of doing something similar, what advice would you give them on how to start?
I think I think similar to what we did, do a bit of groundwork, really find out what the problem is before you want to set something up, and really talk to people that the clinic or I guess the service that you're setting up. Make sure that you're actually taking into consideration what the population needs over there, as opposed to replicating what you've just, for example, taken from Fiji. It's not, nothing adopted from another place is going to be best fit. You need to look at what's most important to your population out there, what your main problem is. This might not even be a problem to your island nation or to your country, the things that I've talked about. So you need to really make it, really need to tailor make it to suit your situation. The other things would be really stakeholders. So if you saw, we had different stakeholders have representatives on the asthma team. So it's not a one-person job. It's never going to be successful if it's just dependent on one person driving it. You need multiple stakeholders. I don't think I've mentioned the intensive care doctors as well. They were instrumental in this, trying to talk to patients when they were extubated, saying, hey, we don't need to see you back here, and you really need to go to Raksha's clinic. I'm like, this is not my clinic, but also happy to help you.
Any other questions? Chantal, you look like you've got a question there. Where are you dialing in from, Chantal?
Any stories that you want to share from your own experiences?
Anything to say, Chantal? Yeah, no, it's okay if you don't. You look like you were about to ask a question. Oh, okay. Who else? Oh, we've got Angao ICU online. Who have we got from Angao? Are there lots of you?
Hi, Beth. There's just 4 of us.
Oh,
We kind of came halfway, so sorry.
Oh no, that's all right. It's lovely to have you join us. Thank you. Have you got anything to add or suggest, or any questions you want to ask? Because I'm sure the situation in Angao is probably different, but maybe similar to what they see in Fiji.
Yeah, we in our hospital we don't have an asthma clinic like what you were presenting today. It's quite interesting, and it's a good presentation, very interesting. I wish my friends from ED were here to hear that, the whole presentation, but they're not here. But it's something for us to consider, like very interesting to see that.
May I ask, do you get a lot of intubated asthmatics?
No.
No. Okay.
I cannot speak for the emergency department, but in ICU, we don't get a lot of asthma patients compared to the surgical cases we get and other medical cases.
Do you think that's because they're treated well in the ED and they never make it up to ICU?
Yeah, I guess I would say that, yes.
Yeah,
yeah.
That's really great. That's fantastic. Now I see we've got Erica online here. Erica, where are you in the world at the moment? Erica's been all over the place recently.
Sorry, I am on my phone and having some difficulties. I am in Korea. I just landed, so I'm sorry for joining late. Raksha, I'm sure it was a wonderful presentation. Given that I didn't get to see all of it, you may have covered this, but I'd be really interested to know, is this something that we manage well in Darwin? Or do you think that there's a place for an asthma clinic in Darwin as well?
I was surprised you'd ask me that because I was thinking about it last night. I was like, this sounds like a question I'm going to hear. To be fair,
I'm here for you.
Setting up an asthma clinic is very much a primary health sort of project to do. And given that I predominantly worked in intensive care here, I am hoping it exists out there. But I think the medical or health setup in Australia is very different, or in Darwin also, is very different to what we have in Fiji, where you would access your GP through Medicare, being bulk billed and sort of supported by the government, and have asthma action care plans and things as such in place for patients to access ahead of time. And there's a huge push that you see even when putting your kids into school. Do they have an asthma action care plan, since they've got a diagnosis of asthma, things such as that in place already. So I'm assuming that there are clinics out there for this, but they're mainly nurse-led clinics. I have been to asthma clinics in Melbourne, which I tried to have a look at how it was set up before I set one up in Fiji. And they're mainly nurse-led clinics. So I am quite sure they must be out here somewhere as well in Darwin. Yeah. The difference that I've seen here, though, having such clinics in place in Australia, is that you don't really get severe asthmatics being intubated in ICU just purely for asthma. You might have patients getting intubated and ventilated because they've had a really bad few months of respiratory illnesses like a pneumonia or like a proper chest infection that's then led to them getting an asthma attack and getting intubated. But you don't really see the volume of asthma intubations the amount of patients I used to see in Fiji here at all. I mean, I can't remember in all my time being here, I really can't think of anybody that's been intubated just purely from asthma.
Yeah, it's an interesting one because I can imagine some of the problems we have around, consistency of people taking their medications and filling their scripts and that kind of thing. We would have a lot of problems with that in Darwin around just people having access to the medications that they need. But it sounds like it's probably quite well managed in community clinics as well.
Yeah, I think you do see it in COPD, similar sort of themes of, okay, I'm not using this, or no, yappa, no, not going to use this. You see a lot of that. But again, it all boils down to, and my chats with patients on the ward is all about why. What is it in their belief systems to figure out what it is for them that's stopping them from using these.
Good job.
Well done. Yes, well done indeed. Has anyone else got any comments or questions to ask before we say goodbye for another month?
I also just really want to know where Chantal and her friend are.
Yeah, me too.
It's intriguing me now.
Hi, sorry. It's our first time to join, so we're keeping quiet. We're from Papua New Guinea, Alotau.
Oh,
Alotau Minde.
Has Dulcie back in work? Has Dulcie arrived home safe and well?
Oh yes, she was the one who gave us the link to join, so we decided to join today.
Oh, that's wonderful.
That's great.
Hello to her and tell her she did a really, really great job at presenting at the conference in Melbourne.
Okay,
She's amazing.
Thank you.
Yeah. maybe next time it might be your turn, Chantal. she's a good role model and a good mentor.
She is.
Yeah.
Yeah.
Cool. It was lovely to
We're
see
just
you. Thank you
waiting
for
to
joining.
hear. Thank you.
No problem.
No,
Hopefully.
I was just trying.
Cool. All right. What we might do, there's no. Oh, sorry, Chantal.
No, I was going to say thank you for the presentation. That was very informative and important. It's similar to the cases that we see here. We work in medical wards, so yeah, the importance of actually finding out the causes of the asthma, what triggers the asthma is very important. In that way, we can address it. Yeah, and also, like what you said about the spacers, the importance of using the spacers or inhalers before coming to seek medical assistance. It's very important. So, and because we don't have the proper spacers here, we improvise. Yes. So we use these bottles like this 500 ml, bottles, and we just bore holes there that will fit the inhaler, and we teach them how to use it. But we've got a clinic going on as well recently with a new physician that we have. So it happens every Mondays. Not a clinic, separate clinic on its own, but at 40. So it happens on Mondays. Yes, it's very similar to what you presented. But thanks, and we look forward to joining more of this.
Cool. Thank you, Chantal. Well, I think what we might do before we say goodbye, if everyone is able to put their videos on, and I'm going to try and take a photo of us all. Now then, this always confuses me.
Yes.
And are you able to put your video on, Shivani? Or is it not allowed? Oh, that's all right, Carla. No problem. And Denora, are you still there? Are you able to put your camera on, please? Lovely. All right. Hang on now. Mode, win, full screen. Oh, all right. You ready? Say no. Okay, carry on smiling. Smile, everyone. Oh, cheers. Thank you. All right. We will we'll look forward to hopefully seeing you next month. Thank you, everyone.
Thank you.
Bye-bye. Take care.
Good presentation. Bye-bye.
Bye-bye.
Bye. Thank you. Thank you, Beth.
I love that.